It's okay. It's okay.
All right. All right. So, what was I saying? Oh, okay. In the course of treating one or any either one problem, we may end up with the other. For instance, when we treat hypothyroidism, which is basically we're going to end up replacing the hormone. We don't exactly have a perfect dose all the time because are our metabolic needs static? Do they remain the same every day, every age?
No,
No.
Okay, so
no.
let's say that a patient gets pregnant. Will the metabolic needs be the same?
No.
No.
Are your
Not the
metabolic
perfect.
needs the same right at this hour than it was an hour ago when you were testing?
No.
Nope. Nope. Nope.
No, right? Okay, so it constantly changes whether it's due to stressful conditions or from, let's say, developmental stages. Say when you were younger. Look, imagine a baby, for instance. Look at the metabolic rate of a baby. How fast do they grow within the first year?
Rapidly.
I mean, they can double their height, right, in the first year, and then they triple their weight. Um, I mean, we can still. I can probably still triple my weight now easily with this pandemic, but as far as the height though, I can't do anything about that, right? But anyway, the my point here is the treatment for one can definitely lead to the other problem. So I may start with hypothyroidism, then I may end up with hyperthyroidism. So that's why it's listed here as one of the causes. Besides an autoimmune disease, we also have thyroid surgery, which is one of the treatments for hyperthyroidism, along with other treatment modalities. So Hashimoto's thyroiditis is the most common form. It's the autoimmune form of hypothyroidism. Now, we will discuss goiter later because we will see goiter in both conditions actually. Let me cover first. Let's look at why there is enlargement of the thyroid gland in hypothyroidism because the common understanding is when you see goiter, you automatically think about hyperthyroidism, but it actually also occurs in hypothyroidism. And can someone read this, please? Thank you, Miss Fob. So why does goiter happen in hypothyroidism? Marie?
Hypothyroidism is a major cause of gout and develops secondary to thyroid gland
No, sorry. I can you see
hypertrophy.
my screen? The statement I'm highlighting.
Okay. Develops secondary to thyroid hypertrophy and an attempt to produce normal amount of T3 and T4.
Okay. I'll explain further how this develops. Um, moving on, there are more women affected here, and look at the age group. Who among you here are between 30 and 60?
Me.
How many females do we have here?
Me.
All right. So 12 of you are within the risk group, right?
Yes, Professor.
All right. So, however, it's doesn't discriminate really between men and women. So it just says that more women are affected. Table 43.1. We won't cover the whole. Let's just review um, hormones involved, particularly in diagnosing as well as monitoring treatment. So let's discuss A and P. Can you see the whiteboard?
Professor, sorry, I cannot see anything.
Me too, Professor.
How about now?
No.
Yes, I
Yes. Yes.
All right. Okay. So let's say, so you know that the pituitary gland is the master gland, correct? Hello?
Yes.
Yes.
Okay. And they control, it controls all other endocrine glands. Okay, so let's put, say, adrenal glands here, and then we have the thyroid gland. So looking at that table, which hormone is released by the pituitary gland in order to control the activity of the thyroid gland?
PTH.
What was that, Mr. Chen?
PTH, is that right?
The thyroid gland, not the parathyroid.
Oh,
TSH.
Very good.
TSH.
All right, so it stands for thyroid stimulating hormone. All right, so in chapter 43, the problem lies with the
Professor,
thyroid gland.
sorry. Professor.
Yes, go ahead.
BT is waiting. You need to let her in.
Yeah, I keep clicking and it won't respond. Can you ask her to leave and enter again? Because I'm clicking admit and it doesn't work.
Okay, all right.
Nothing's happening. Oh, I think she's still will not work. Is she here? Okay. Yeah, just give me a heads up when she. Oh, never mind. BT was already in actually earlier. I had no idea she disappeared.
I'm here.
Okay, all right, welcome back. All right, so where was I? Okay, in chapter 43, the problem lies with the thyroid gland. So let's use Hashimoto's thyroiditis, okay? Hashimoto's. So the problem is with the thyroid gland, not with the pituitary gland. So chapter 41 is talks about the problem with the pituitary gland. This is chapter 43. The defective gland is the thyroid gland. It is not working properly. It's not producing enough T3 and T4. It is incapable of doing so, caused by an autoimmune problem. It's an autoimmune problem, so we really don't know why it happened. Contributing factors, of course, as listed under the pathophysiology, are low intake, low dietary intake of iodine, for instance. But let's focus first on Hashimoto's thyroiditis. So the problem again is with the thyroid gland. It's incapable of producing T3, T4. So as a result, what will be the levels of T3 and T4 here? If the thyroid gland is okay, so let's begin with this problem. So both are low. So as this circulates in the bloodstream, reaching the pituitary gland, because our body works by negative feedback, what will the pituitary gland do in response to seeing low levels of T3 and T4?
Increased TSH.
Very good, Henry. So TSH release will be increasing. When it reaches the thyroid gland, will that solve the problem?
Yes.
So will it cure the Hashimoto's thyroiditis?
No.
Okay, very good. So no. However, because the problem lies with the thyroid gland. However, is the pituitary gland aware of that problem?
No.
No. So when it sees that there is no response, T3, T4 remains low. When that reaches the pituitary gland, what will it do again?
Continue to stimulate TSH.
Very good. Continue releasing TSH. So you see when you draw blood from these patients as ordered, results will come back that the T3 and T4 levels are low, TSH is high. Now let's do another scenario. What if the thyroid gland is normal and the pituitary gland is not? Such as in the case of secondary hypothyroidism. So let's see. If the pituitary gland is defective, which is discussed in chapter 41,
Then
what will
it's
be the
decreasing
TSH level?
TSH.
Very good. So this time the
Decreasing.
TSH is low. What will be the resulting?
You will cause
Decrease T3.
T3 and T4 low.
What will happen to your T3, T4 if the pituitary gland is under secreting TSH?
Decrease.
It will
Too
also
low.
be low. So you see the difference here in primary. Let's call this number 1 primary, and then this one here is secondary. In primary hypothyroidism, there is an inverse relationship between the TSH and the T3, T4. Whereas in secondary rather, in secondary hypothyroidism, there is a direct relationship. If the TSH is low, T3, T4 levels are also low. You see the difference?
Yep.
Okay. Any question, Jessica?
No.
All right. Okay, so that's how you interpret the table 43.2. So here we're talking only about hypothyroidism, so we're assuming this is primary. So T3, T4 are both low in hypo, high in hyper, but look at the TSH. They make a distinction here between primary and secondary. So in primary, it is opposite. TSH is high, whereas T3, T4 are low in hypothyroidism. But if you see in secondary or even tertiary hypothyroidism, now it is low, and so are your T3 and T4. You see the difference between primary and secondary. But like I said, only the cause and the laboratory findings will be different. The treatment, signs, and symptoms will be identical. Okay.
Can you just explain
Yes,
to
Mr.
me
Chen.
what is the difference between the free and total?
Free T4.
Any one of them.
What was the question again?
Okay, I see the value for free T3 and total T3. I don't know the difference between both.
Oh, okay. For our purpose, we're talking about free T3 and free T4 in the sense that they are not bound to any other substance, meaning they are circulating in your bloodstream. They're found in the plasma, meaning they are the ones that are capable of actually entering and leaving the cell. That's the form of the T3, T4 that we will be looking at when we're looking at the disorder.
Got it. So they are free to bound to anything. All right, got it.
Yeah, they're free. I mean, they're not bound. They're not in a compound of some sort, meaning they are literally circulating in your bloodstream, and therefore are capable of entering and leaving the cell. Okay, as you can see here in the illustration, the thyroid gland is normally not palpable. Here, this enlarges. Look at the increase in size of your neck now because of the enlargement. Manifestations. Let's keep this simple. All the metabolic activity of all cells here are increased. No, sorry, we're talking about hypo. All the metabolic activity here are decreased. Everything is slow. So let's look at it by system. Let's start with your mental function. What will you likely see? If there is low metabolic activity, how is your concentration?
You feel weak, tired, fatigued.
Okay, let's begin with, yeah, those are all correct. Everything is slow. Let's start with your neural function. So how fast can you think?
Traceability. Great.
I'll be slowed down.
All right, so attention span, can you concentrate? Are you going to understand something normally?
No.
No. So everything is slow. Let's go down to your cardiovascular. So we start from the head now to your chest. What will be your heart rate?
Bradycardia, slow.
Your blood pressure will be?
High.
Blood pressure, meaning your heart rate's low. So bradycardia, what will happen to your blood pressure as well?
Low.
Also low. What about your respiratory rate?
Bradypedia.
Okay, it'll also be slow. What about your GI? Let's go down to your GI now. So describe peristaltic activity.
Decrease, gonna be constipated.
Okay, so decrease, you'll have constipation. Let's talk about overall metabolism. Do you have appetite? Decreased. You have anorexia, but surprisingly, despite not eating enough, what do you think will happen to these patients' weight?
They gain
Let's say
weight.
they eat very little.
Weight gain.
All right, there will be weight gain because no matter even with the little food that they're able to eat, they're not really expending any energy here. They're not consuming much, so therefore, what does the body do again? We just finished diabetes, particularly diabetic.
Turning to fat.
Exactly. So these patients will have weight gain as a result. And then you'll have, as stated here, you have cold intolerance and a lack of sweating. In both hyper and hypo, there are hair changes. In both, they will have some extent of hair loss in both conditions. We haven't even begun with the complications yet. So let's go with any question on signs and symptoms, how these patients will present. Okay, let's go to diagnosis. Definitely, we already looked at table 43.2, showing you the lab findings. Medications now. This is the easy part. I shouldn't really say that. Easy in the sense that we have one treatment. So your thyroid gland is unable to produce enough T3, T4. So how do you think we will treat this?
Give them medication that replicates T3, T4.
Okay, so we will give them the actual hormones in the form of levothyroxine. This is the most common brand. And for how long will be given levothyroxine? A couple weeks.
Forever.
Depends on the value, right?
Forever and ever.
Oh, lifelong. Sorry.
Lifelong.
All right, so this is taken for life. Make sure the patient understands this. Now, I know I said it was easy, but not really. The problem here is, just like I said earlier, our metabolic needs do not stay the same. It's not static. It changes constantly. Now, the common principle being used here with any medication is, including pain medication also, when we start something, we must start low and then go slow. Meaning we start at the lowest dose and then increase it from there. We are trying, why we do this is we're trying to limit the possible
Overdose.
side effects, right? Specifically with cardiac complications. Chances are these patients already have some heart problems resulting from the disorder, I mean, before they were diagnosed. So we need to be careful. The doctor will start these patients at a really low dose and then go from there. We will increase it in increments, and how the doctor decides when to increase it and at what dose is based on our T3 and T4 and TSH levels. So when we see the levels, when the doctor sees the levels are now close to normal, or normal would be ideal, and the patient's signs and symptoms are improving, then they will likely stay at that same dose for a while, and then until the next lab draw is due. Are you okay so far with that? So
Yes.
yeah, the most important here is, let's say you're the nurse giving the first dose. You have to be careful with giving that first dose. Make sure there are our priority here is the cardiac symptoms. That way we monitor the patient, how they respond when we give them the hormone. So check your pulse, check your blood pressure, monitor them, and then advise them, that when they're discharged, they may not see the changes right away. Please read the evidence-based section here on your own. I do have a question on this. I mean, you have the blueprint already up. I know nobody has looked at it yet, but when you do your review later, you'll see that this is one of the items I have on your blueprint. Here's a safety alert. Again, I already mentioned that we need to watch these patients, especially with either the first dose or the first dose of the new dose. Meaning, as we increase or decrease the dose, when you give that new dose, especially if it's a higher dose, make sure you really monitor cardiac function. Complications can result. This is let's imagine all the signs and symptoms we saw earlier, but then you double them. You increase the severity. Most problems that lead to the complication is, one, either the patient was never diagnosed, meaning they went about their lives not knowing they have hypothyroidism, so they were never given supplemental hormones, or they know that they have hypothyroidism and they're not keeping up with their doctor's appointments, meaning they're on the same dose for too long without any monitoring, not realizing that their hormone needs have increased. or they have a treatment, but then maybe a insurance problem, or simply just non-compliance with therapy. So a severe form of hypothyroidism or severe type is called myxedema coma. Don't be fooled by the term coma, because coma here is actually a late sign. The patient will have more serious problems before they go into a coma. So here are your characteristics. So imagine this patient with all the signs and symptoms we talked about earlier, but then just make them really worse in a short period of time. So severe hypoxia, because their respiratory rate will be really low. So if your oxygen levels are low, what happens to your CO2 levels?
Low.
Oxygen is low, so CO2
yeah.
levels will...
It will increase.
Okay, very good. So that can lead to respiratory failure. We'll discuss respiratory failure next semester. You'll have severe fluid and electrolyte imbalances here. You have severe hypothermia, and mental function declines pretty rapidly. So if the patient doesn't die from shock due to severe hypotension, they can also die from hypoglycemia and hyponatremia. When taking care of these patients, whether or not they're in myxedema, you should always be careful about giving any CNS depressant. So any drug that alters your CNS function, such as sedatives, for instance, analgesics or anesthetics, they must be given at lower doses in patients with, especially if they have myxedema already. Here's another warning. Give me examples of sedatives. That way you know exactly what you should give with caution. What are examples of sedatives?
Oxy.
Okay, narcotics, oxycodone, oxycontin. What else? Give me examples of benzodiazepines.
Valium, diazepam.
All right, diazepam. What else? So you're sleeping
Lorazepam.
pill. Okay, lorazepam, another one. So any drug that lowers your CNS function. Most common again are sleep aids, anti-anxiety medications, or strong pain medications. They're all CNS depressants. So you not only should, plus one thing to remember is all metabolic activity is low here. So does that include drug metabolism?
Yes.
Yes.
All right. So now let's say, can you give them the same doses as everybody else?
No.
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 Can you give it at the same frequency as everybody else?
No.
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 And
So bear in mind when you're dealing with hypothyroid patients, especially if they're exhibiting signs of myxedema already, that you're careful with those. Here's now a summary of our signs and symptoms, which otherwise we didn't include all of them earlier. There is decreased libido here. They'll be sleeping more than usual, and weakness, of course, because of low energy, low metabolic activity. And here are your possible nursing diagnoses in order of, well, between, these are your priority, let's put it that way. So perfusion comes first, then nutrition, and fluid overload. Let's summarize your nursing interventions. In myxedema specifically, which is severe hypothyroidism, these patients are now in severe hypoxia. So you give oxygen first. Now, if you go down the list, vital signs and weight. Now, in Can myxedema, specifically myxedema coma, is that a life-threatening complication?
Yes.
All right. So how do we give the levothyroxine now? Since these patients, when you have hypoglycemia, hypotension, do you think these patients are conscious when this happens?
No.
No.
No. So how do we give our levothyroxine now? Can we crush it and put it in their mouth?
IV.
Very good. So IV administration of levothyroxine is necessary in mixed edema. You of course have to address the other symptoms, mainly the hypotension. So what interventions can be given with hypotension? We just finished that for your first exam. How can we raise blood pressure?
Fluid.
Vasoconstrictor.
What was that?
Keep fluid.
Vasoconstriction.
Fluids first, okay, and then if needed, so let's say we get to a point where they're in shock, yes, maybe we can consider vasopressors. What else? Especially if you have, could these patients have the need for intubation, perhaps?
Yes, because they unconscious.
Okay, so they're unable to protect their airway, so most likely these patients will also need intubation. We'll discuss that again in another your next semester. They are now unconscious, so therefore unable to protect themselves. So make sure they're in a aspiration precaution position, and then skin protection here to maintain integrity. And what else again? This is again a unconscious
We got turn
patient who is
area
not
about.
very mobile.
We gotta do freaking turning.
Okay, turning. And what about prophylaxis? Are they at risk for DVTs?
Yes.
Yes.
Okay, very good. There you go. And these are our teachings. So majority of your education here will be, of course, how to take the thyroid hormones. Is there ever a instance that we can stop this for whatever reason? Let's say this patient goes to the hospital for another reason. Let's say they need surgery. Can we, because they're NPO, right? When they go to surgery, can we go without the hormone a couple days? That's okay, right?
No.
No.
Okay, very good. Why not?
I mean, the signs and symptoms can be exacerbated, preventing them from having the surgery. So
All right. What happens to their metabolic needs during surgery? Do they need more or less?
More.
Less.
You are injured. You are
Injured.
somebody's cutting you up. Somebody's making you lose blood. So do you want your metabolic rate low or high?
High.
High.
You're injured, you need a higher metabolic rate. So can you go without the thyroid hormone, especially if you're hospitalized?
No.
No. So if needed, and the patient's on levothyroxine, what's your responsibility? The doctor ordered NPO. So you're just gonna disregard the order, right?
change it to
Say,
IV.
Okay. We're gonna call it.
all right, so notify the physician. Doctor, this patient has hypothyroidism. They're on 250 micrograms of levothyroxine. What do you want me to do? He's NPO. All right, so chances are you'll be given an order to give it with sips of water, or if needed, it may be given in in IV form. So this is one of the drugs that must never be stopped, along with steroids. What else? What other drugs can't you stop? Can you stop anti-seizure medications?
No.
No. So goes along with those groups. All right. Any question on hypothyroidism? All right, let's go now to the exact opposite. This time we have hyperthyroidism. So let's look at the same pattern here. We'll just do everything in reverse. So this patient has hyper metabolism. Everything is high, everything is fast. In hypothyroidism, what was the most common form again? The autoimmune form?
You said hypo?
What did we call that disorder?
It's Hashimoto's.
Hashimoto's. Okay. So the equivalent here in hyper is called Graves' disease. Another autoimmune problem, this time resulting in higher levels of T3, T4. And just like what we saw in primary hypothyroidism, so in primary hyperthyroidism, which is Graves' disease, what is the relationship between T3 and T4 and TSH?
Negative feedback.
So if T3,
Too
T4,
high?
let's go back up here. Let's go back to table 43.2. Right here. So this time we're looking at hyperthyroidism. So they're high in hyperthyroidism, right? Look at in primary. What is the TSH level in primary hyperthyroidism?
It's decreased.
It's decreased. So same exact pattern as with Hashimoto's, only the reverse. So T3, T4 this time is high, TSH is now low. What about if it's secondary hyperthyroidism, this time caused by hyperpituitarism?
Increase on both.
All right, so the TSH will be high, so is the T3, T4. Very good. Any clarification on that? Anybody? You're good, right? Okay, let's proceed with, I want to go down. All right. So same exact pattern as we saw in hypothyroidism, this time it's now the opposite. So we have an overactive thyroid gland here. There is still goiter, because you saw the goiter earlier in hypothyroidism. The reason given was because of the high TSH, the thyroid gland is forced to work harder without any corresponding results. As a consequence, it enlarges. Here, the thyroid gland is already very hyperactive, and for that reason, what happens to blood flow to any organ that is very hyperactive?
Decrease.
It will increase blood flow to that organ. So the thyroid gland here becomes very vascular as a result, and we'll consider that hypervascularity in surgery later. So manifestations, if you look at them side by side, it's the exact opposite. So if you had low heart rate earlier and low blood pressure, this time you have high, everything's high. Because of the increased blood flow to the thyroid gland, you will actually hear a bruit. What is a bruit again? In fundamentals, what does this sound like? Can you imitate the
Fair
sound,
amount of
Biddy?
blood flow.
It's like a
Can
clot.
you? Sounds like what? Can you imitate the sound? Or Panya, do you know what a brewery sounds like?
It's like a gushing sound.
All right, so there's like a okay, so you literally hear blood flowing through it. So you put your stethoscope over the neck, you'll hear it. We don't have cold intolerance anymore. Instead, we have heat. Instead of constipation, we have diarrhea, loose stools constantly. Here we have ferocious appetite. However, look at this. Isn't this nice? You have a really high appetite, you have a high food intake, but look at the weight. You're losing weight, right? What can be better? Not really. This is not good because the patient here actually cannot eat enough food to supply the increased metabolic rate. In fact, they will go into a negative nitrogen balance. They will become very malnourished as a result. So they'll lose weight, they'll have muscle wasting as a result, um, and all sorts of metabolic problems. So they're tired, besides being hyperactive, they can't sleep. There will be, we forgot to mention earlier, there was amenorrhea in hypothyroidism. So about the same here in hyperthyroidism. And as I mentioned already, there's some hair loss in both conditions. Here's a classic manifestation. There will be exophthalmos. This is a combination of several factors. One is the eyelid retraction. See here, if we compare both pictures, you still see the eyelid here. You see the eyelid here in exophthalmos. It's missing, right? So the eyelid retracted here, which contributes sort of illusion because you have no eyelid, so the eyeball seems like they're popping out. Another is there is some degree of fat deposits behind the eyeball as well. Here you see the same goiter as seen in hypo. We'll talk about more about eye care later because the result of the eyelid retraction means they can't close their eye completely. So this eye will be the eyes will be prone to injury here, to dryness and possibly injury. Lab findings. This test of RAI, radioactive iodine, is not commonly used anymore. Some doctors still order it. However, their use is decreasing because it is a radioactive substance. There are other ways we can make a diagnosis besides using radioactive iodine, but let me just explain why they use this. There's really technically no other organ that uses iodine besides the thyroid gland. And iodine, as you know, is needed to do what? Why do we need iodine? To make what?
X-ray.
Mr. Chen?
X-ray.
Oh, yeah, okay. So you're talking about the contrast, right? No, in the body, in our body.
Yeah.
Why do we need iodine?
To make thyroid hormone?
Very good. So they're basically you can call it your raw material that you need in order to make T3, T4. So since the iodine is pretty much the only organ using it, so it would make sense that if you give them a radioactive iodine, which organ will suck it up?
The thyroid.
The thyroid. So when you take a scan, will the radioactivity show in the thyroid gland?
Yes.
Okay, so as simple as that. So you give them radioactive iodine by mouth, and then you take scans of their neck, then it will show up on the radiology test. Like I said, there are other ways to do it. We can do thyroid ultrasound, for instance, that you can, and then lab work specifically. So it's not really necessary. So most doctors nowadays are avoiding the use of RAI to make a diagnosis. Let's go now to treatment. The main treatment here is really surgery. However, we need to prepare the patient first for surgery, so we can't really just decide to do it tomorrow. Plus, the fact that you agreed with me earlier, right, that when a gland is hyperactive, what happens to the vascularity of the organ?
It becomes very vascular.
Very good. There's increased blood flow to it. So what could be a consequence if it's a very vascular it's in a very vascular, hypervascular state, and then you cut it out, what's going to happen?
Hemorrhage.
Okay, so we probably can't stop the bleeding. So the plan is we'll have to destroy, pretty much for lack of a better term, we're going to kill the thyroid gland in order to decrease the size. So we were giving them anti-thyroid medications in order to achieve that. So we want the thyroid gland to be as close to normal size as possible before we do surgery. So let's do the pharmacologic treatment first. We have what's called thionamides. There are two. We have PTU, or propyl thiouracil, and methimazole. A third is lithium. The purpose of these drugs, again, they are anti-thyroid medications. So typically, basically, they destroy thyroid tissue. Side effects, okay. Side effects are, what do you think will happen? Remember, treatment for one leads to the other. So with this treatment, what symptoms could develop? Because you're pretty much destroying thyroid hormone.
Bradycardia.
Hypothyroidism. Okay. But that's our goal anyway, because we can't put these patients on medication. Again, medication typically will be a short-term approach here until the patient receives surgery. Surgery will be basically two. You either have total thyroidectomy, I mean you remove the entire thyroid gland, or you can do subtotal, wherein you leave a part of it behind. In which case the patient only develops signs and symptoms of hypothyroidism for a short time rather than lifelong. But let's look at the plan. There are, let me see, oh, here it is. Okay, table 43.3. These are, there should be another, anyway, the thionamides, because what age group are the women here that are affected again?
30 to 60.
Okay, are they within childbearing age? Can they get pregnant?
Yes.
Yes.
Okay. Pregnancy is absolutely, if they get pregnant, then they're pregnant. But the treatment will have to be considered here, because depending on which trimester they're at, the drugs are teratogenic. So it's not discussed here. So I'm going to have to refer you to your drug book, similar to what you did for TB drugs for exam 1. Please read on PTU and methimazole. Find out which of the two are okay to take during which trimester. Do you understand your homework? All right. So
Yes.
find out which drug is safe to use at which trimester. All right. Okay. So once we're into the therapy, the patient's been on several weeks of PTU and or methimazole. Oh, by the way, if you look at, I almost forgot. Look at the action of these drugs. Okay, so they inhibit synthesis of thyroid hormone. Same thing here. So they act similarly because they're thionamides after all. Now, the other drug that's used down here, which is iodine, in the form of saturated solution of potassium iodide. Now, the this is basically still iodine. So when you give it, this is the reason, by the way, why we give iodine. large amounts of it. Can you read this for me, Mr. Bello?
Can you hear me?
This one, the action of SSKI.
Inhibits the release of thyroid hormone by decreasing vascularity of the thyroid gland.
Okay. Have you ever been to a buffet lately? Or before COVID, you've been to a buffet, right?
Yeah, prior to
Yeah.
COVID.
How many trips have you made to the buffet table before you say this is good?
I eat a lot, so maybe about 3-4 trips.
Okay. Now, if I offer you more food after those trips, are you still gonna take it?
No, that's not good.
No, right? So you said no. Why did you say no? It's free food.
At that point, I can't take any more. So
Exactly. So this is how iodine works. Because technically, if you give iodine, that's going to stimulate thyroid activity, correct? However, if you give them too much at one time, just like you refuse the food because you've had enough. So technically, it will suppress thyroid activity if you give it too much at one time. That's the theory behind giving large amounts of iodine preparations. The reason for giving this, by the way, is only to prepare the patient for surgery, meaning when we're close to the date of the surgery, we'll put them on SSKI, the purpose of which, again, is to suppress thyroid activity, decreasing its vascularity. And then once we're close to normal, then the patient can go have the surgical removal of the thyroid gland. Any question on this one? I leave you responsible for your nursing responsibilities, all right, on how to give it. These are self-explanatory, so make sure you understand this could be a select all that apply question as part of pharmacology. So now the patient's being prepared for surgery. We gave them thionamides as well as iodine preparation. So now comes the day of surgery. Diet, by the way, will also give them a high calorie, high protein diet because remember, were they in a negative nitrogen balance?
Yep.
Yeah, they had weight loss, right? So they need to be able to recover after surgery. So they need good nutrition before surgery. So we give them that. Oh, one last thing. Since you're giving all three here, PTU, methimazole, and SSKI, now make sure you give these two first, either one of these, before you give this. Because like I was saying, this is iodine. It will trigger thyroid activity. However, if you give the thionamide first, look at their action. They divert iodine pathways. They block combination of iodine with a protein. So therefore, to be safe that we don't trigger thyroid activity, never give this first. Give the PTU or the methimazole first, and then 1 hour later, you can give the iodine preparation. Clear? All right, this is just for safety guidance. All right, next is, okay, let's go to surgery now. We do pre-op teaching, which is what to expect after surgery, pretty much. And then we tell them if it's subtotal thyroidectomy, they will probably just use the thyroid hormones for a while until the thyroid gland returns or resumes its function and compensates for the loss of tissue. However, if it's total thyroidectomy right here, then the hormone replacement will be for life because basically they have hypothyroidism now. So let's prepare for complications. So we teach the patient that it's inevitable that they may suffer hypoparathyroidism, or basically hypocalcemia, because when we remove the thyroid gland, there will be either injury or removal of the parathyroid tissue as well. Others are damage to the laryngeal nerve, which will cause hoarseness of the voice and may have some swallowing problems immediately post-op. I'm out of time. I'll have to interrupt class, so we will continue next week. So we'll have a short quiz, same quiz, only up to pre-op. All right, only up to the pre-op section of hyperthyroidism. Any questions?
Nope.
Alrighty, I'll see you soon.